Okay, Rebecca, I would love to give you the floor for opening remarks. You're muted.
Thanks, Devin. So welcome, everyone, and thank you so much for being here for today's conversation and for engaging with the Inter-American Dialogue. The COVID-19 pandemic, it has affected all of us, and it has strained health systems across the Americas. So today we're here to talk about cancer, and in particular, the ways COVID-19 has delayed preventative services and treatment. The data is still being collected, but early indicators suggest that these delays have led to higher cancer mortality rates. And cancer is something the region was already struggling to address. It's been reported that 80% of people living in Latin America and the Caribbean experienced interruptions in cancer care and other preventive activities due to health systems overload during the pandemic. According to the America's Health Foundation, a range of barriers in getting cancer treatment and services have created a $5 billion economic loss to patients and healthcare industries across Latin America and the Caribbean. But these challenges also present an opportunity. They demonstrate the urgent need to strengthen our healthcare systems and put safeguards in place for the next pandemic or global public health crisis, which is critical to care for our most vulnerable populations and ensure that our healthcare systems can meet unforeseen challenges. My hope is that we come away from today's conversation with new insights and ideas on what these measures should look like, as well as tangible policy recommendations for actors working in this field. Moderating today's conversation is Alessandra Justin, the CEO and founder of Catalyst Consulting Group. Alessandra has a very illustrious career in the international arena, working in health, business development, marketing, and media engagement in nonprofit, but also for-profit sectors. She started her career at the United Nations, creating training programs for women-led businesses. She then worked at International Planned Parenthood Foundation, developing public-private partnerships with pharmaceutical companies, and at the American Cancer Society, where she was in charge of global advocacy and capacity building for civil society groups. Alessandra is going to be introducing each of our fantastic speakers and guiding our conversation today. After the conversational style panel, we're going to have time for questions and answers. Please share your questions by using the Q&A function in Zoom, or you can email them to meetings@thedialogue.org. And I want to give special thanks to members of the Dialogue's corporate program for their support in making this event possible. We've got Eric Brand, who directs our corporate program, and Devin Severson, our very talented program assistant, for their hard work in putting this session together. With that, I'm going to give the floor to Alessandra, and thank you all again for joining us today.
Thank you so much, Rebecca, and thank you to the Inter-American Dialogue for pulling this session together and getting such great groups to be able to speak on this panel. We have a nice combination of the World Bank, Pan American Health Organization, and the America's Health Foundation, talking about some of the research and some of the programs that they have addressing the issue of COVID and interruptions in cancer care. I want to introduce our panel, and I'm going to start with our representative from the World Bank, Dr. Cristiana Herrera, who is a senior health specialist in the Health, Nutrition, and Population Global Practice of the World Bank. Dr. Herrera worked as a primary care doctor in the municipality of Santiago, Chile, before moving to work in health, public health, and policy issues. He is a former health policy analyst at the OECD and a former senior health official at the Ministry of Health of Chile. He is a medical director for the Pontificia Universidad Católica de Chile and holds a graduate diploma in international relations from the University of London and an MBA from the Universidad de Chile and a Master's of Science in Public Policy from the London School of Economics and Political Science. Thank you, Dr. Herrera, for accepting this invitation. Next from the PAHO, we have Dr. Ansam Hennis, who is the director of the Department of Non-Communicable Diseases and Mental Health both at PAHO and at the World Health Organization. Dr. Hennis obtained his medical degree from the University of West Indies and is qualified in internal medicine in London. He was a Wellcome Trust Clinical Epidemiology Fellow to the London School of Hygiene and Tropical Medicine, graduated with a Master's of Science and PhD degrees in epidemiology. Dr. Hennis has been a professor of medicine and epidemiology at the University of West Indies and a research associate professor in preventive medicine at the Stony Brook University. He has led population-based cancer registries in Barbados as well. And so thank you, Dr. Hennis, for joining us. And we are rounding out our session with our panel with Dr. Mariana Rico, who is the medical director of the America's Health Foundation. She is a physician based in Bogota, Colombia, with a public health background dedicated to promoting equitable access to healthcare in Latin America. She has a broad experience in public health policy, focusing on healthcare access barriers and inequities and advocacy solutions in many different fields, including rare diseases, oncology, autoimmune and infectious diseases, as well as women's health. She has led over 20 consensus conferences, task force, and reports on these topics during her time at the America's Health Foundation. So thank you to all three. The idea behind this session is that we're going to have questions and answers, very free floating. We also, please, I invite you to write into the chat with any sort of specific questions you may have for our wonderful panelists. I'm going to start out with the World Bank because I feel like the World Bank is probably dealing with the issues on the most macro level. And I wanted to ask Dr. Irid, given the negative effect of COVID on budgets of health systems in Latin America, how is the bank addressing the need for more treatment and screening for cancers that have advanced during the pandemic?
Thank you very much, Alessandra. And and thank you for the Inter-American Dialogue for organizing this great webinar. So from the World Bank, as you say, Alessandra, we normally take a more broad perspective to all these issues. And during the pandemic, this hasn't been different. Of course, we have supported with financial resources, but with knowledge and in the field work as well. But I must say that we try to take an approach, all issues from a health systems perspective, right? So more broadly, because we believe that health systems challenges are the structural challenges for other conditions such as cancer and cancer control. So that's why this health system approach. And in that sense, we have identified the main weaknesses of health systems that certainly have correlation with cancer control and the problems that we see there. So, for example, we see I can name 6 areas. So one, and the very first, of course, related to prevention, is the insufficient prioritization of prevention policies that in the end leads to a higher burden of risk factors for cancer, right, in many ways. Then the second point, fragmentation of health systems. And this leads in many ways to health inequities. And we see health inequities in cancer outcomes for patients and related to this fragmentation. So we have a piece of health systems for the wealthy, then another piece for middle class, you could say, and another piece for lowest income populations. And we see this type of fragmentation and other types of fragmentation as well across health systems in the Latin American and Caribbean region. And again, as I said, this correlates with the outcomes for patients. So that's very clear. There is a lot of research showing this. Then number 3, low public spending. So we know, and we have a lot of data showing that public spending in health is a major issue that in the end leads to high out-of-pocket spending from households, from families. And of course, that's the one we want to avoid. And this is a challenge, a macro challenge, right? This relates to ministries of finance with other actors, not only governments, right? Because we need to have other actors, private sector, and so on, joining this kind of view for, in the end, covering health more broadly, and this will include for sure cancer, and we can immediately talk, for example, of issues such as cancer medicines, right? We know there is an issue there with pricing, with coverage, and so on, that in the end has a correlation with financing. Then number 4, lack of data, right? Data and information is key. We know that this deficiency hinders decision-making at all levels. When I worked at the Ministry of Health in Chile, I was in charge of all this, of health information systems, epidemiology, and so on, so surveillance, etc., including health economics as well, so all the health financing data, so all this type of information coming from different parts of the health system, including from cancer for sure. So, for example, the population-based registries and so on is quite diverse in the region, and there is a lack of this information. Then number 5, poor quality of care. So probably in terms of universal health coverage, the area that has been left behind, we could say, is quality of care. Of course, access, financial protection, and so on is super important. But then if we don't have quality of care, we will be failing either way, right? We won't be providing the best services and the best outcomes for patients. And this relates very strongly with patient-centered approaches in health systems. And this is the case for cancer as well, right? We need to put cancer patients and their families in the very center and help them to move across the cancer care networks, right? We know that patients need to go and pass through different specialties and different health workers, type of health workers, and we need to help them. And here we always mention pathways of cares, navigation systems that will improve the experience of patients and very likely in the end adherence to treatments, etc., and in the end outcomes, right? And the final point, and this is I know I'm taking a bit more time, but weak resiliency on the health systems. And this is very important because a health system that is strong is not the same as a health system that is resilient. These are 2 different contexts. So the first 5 points I was mentioning probably relates to strong health systems, but this doesn't mean that this kind of system will be resilient. So we need to put a special focus on what resiliency means for health systems. And again, this will mean that when a shock impacts a country in general, like a pandemic or like a natural disaster or a conflict, etc., health systems will be able to cope with it. And this requires a different set of policies, a different set of skills, etc. So I put this as a separate point that I think it's important because in the end, the disrupted healthcare services for cancer are directly impacted by having weak resiliency in health systems. So again, taking this more overall perspective of systems and how this correlates for cancer control in the end.
Thank you. Thank you so much. And I think it's interesting that we end on the point of resiliency because I would say that if COVID has identified anything, is that we have a lot of countries have an issue around resiliency. And I'm sure that PAHO is working in the region with ministries of health on that specific issue. So Dr. Hennis, I wanted to know, what sort of technical support is PAHO giving ministries as they plan long-term with the understanding that the scenario for cancer cases and patients and staging has become so much more advanced during the pandemic? So therefore, patients are showing up to the health systems with more advanced cancers and with higher need for treatment, care, and support.
Yes, thank you so much. Well, I'll begin by really just trying to paint the context of what happened with the pandemic. Now, in fact, up to this time, there were 170 million cases in the Americas of COVID, which is about a third of the overall global cases. While in fact, in the PAHO region, we've had about 2.8 million deaths of the 6.4 million deaths or so, which is about 44% of all global deaths. And as my colleagues here would tell you, and I know Christian has a perspective too, that the problem with the region of the Americas is the existing context. And Latin America and the Caribbean is probably the most unequal region in the world in terms of marked social, economic, and health disparities. So in other words, for example, Latin America and the Caribbean, the richest 10% earn 22 times more than the bottom quintile. So the region is considered to be rich, but in fact, there are tremendous disparities in terms of access to care, access to education, housing, poverty, etc. is a major challenge. So these are some issues that were already in existence. And then, of course, linked to that is also the infrastructure status of the health systems. And so when we had the perfect storm of a pandemic, it really was almost inevitable that we'd see the challenges that we had. The system is, as pointed out by my colleague, is that they were never resilient. There was not enough infrastructure, human resources for health, investment in primary health care. And cancer does not only require primary health care, but secondary and tertiary care. So in terms of the questions, what are the kind of technical support that PAHO is providing through ministries? And the biggest challenge that we saw was disruption of services. Many services and many personnel and resources were diverted away from the existing primary healthcare system to respond to the COVID pandemic, which basically meant, in addition to social distancing and issues such as triaging, the primary healthcare services suffered tremendously. And this was particularly so for those which were really resource intensive. So we saw tremendous disruptions across service delivery, from primary care settings, screening, early detection, radiotherapy, treatment, medications, all the way through to palliative care and support. So the area that we saw most disrupted in terms of cancer care were actually the screening services. Also in the PAHO region, as you pointed out, tertiary care is also significantly impacted. So we have done these pulse surveys that look at service disruption. And the last survey at the end of 2021 realized that at least a third of countries reported an ongoing interruption of cancer treatment services. What it means is yet to be seen, because clearly there was postponed or delayed care. It's also foregone care where the services really have not benefited people because they were so disrupted. But with delayed care, there's a potential to recover some of the services. We actually had been working in cancer in PAHO through three significant initiatives. One is the Global Childhood Cancer Initiative, and this was launched in 2018 with the primary goal to increase pediatric cancer survivorship to 6% by the year 2030. We also have been working in a global strategy to accelerate the elimination of cervical cancer as a public health problem. This was launched in 2020 with goals to spur countries to 90% vaccination with human papillomavirus vaccine to prevent cervical cancer, 70% screening with high-performance HPV tests, as well as 90% treatment of women with cervical disease by the year 2030. And the other big initiative that we had in place is the Global Breast Cancer Initiative, which was launched in 2021. And the aim of this is to reduce global breast cancer mortality by 2.5% per year by 2040, therefore avoiding 2.5 million global cancer deaths. And obviously, to get this to work successfully, you need to have health promotion, early detection, timely diagnosis, and comprehensive breast cancer management. So I'm going to give you a little bit more, if you can give me a few seconds more, in terms of the whole issue of the pediatric cancers. Now, as you know, pediatric cancer, childhood cancer, is a leading cause of child and adolescent death. And in the region, it accounts for 29,000 persons, children and adolescents below age 19 being affected annually. Of those 19,000, 10,000 will die from this disease. But I began by speaking about disparities. And this is a classic example of how disparities impact populations and individual lives and communities. So in high-income countries in the region, more than 80% of children with pediatric cancers will be cured. Low and middle income countries, the cure rate is around 20%. So this actually not just translates to years of life lost, but also into worsening economic, social inequities and disparities. So it tells you very quickly some of the issues that one faces in the region of the Americas. Now, so basically what we are seeing now is that as I said before, in terms of trying to respond to the virus, the social distancing, interruptions of commercial activities, et cetera, it exacerbated it. we knew beforehand in the region that particular childhood cancer, and I'm using this just as an example, there are challenges with that poor survival is linked to misdiagnosis, late diagnosis, and another particular phenomenon was high rates of treatment abandonment. People living in rural areas or far from urban centers could not stay for the course of treatment. Also, mortality linked to infections and difficulty accessing timely and quality treatment. And unlike adult cancers, childhood cancers cannot be prevented. So it really requires that you have a robust functioning health system for detection, etc., as you said before, but also referral for higher levels of care. And what we saw really was that in terms of the pandemic and work done with the Latin American Society of Pediatric Oncology found that about nearly 95% of doctors managing young people with cancers noted that chemotherapy was administered for newly diagnosed patients, and about 97% said that treatment was ongoing. But indefinite postponement of treatment or delay of surveillance was seen in about as many as 90%. Outpatient procedures dropped to about 60 or so percent. Surgeries fell to about 45%. Radiotherapy schedules were impacted in as many as 33%. Outpatient consultations fell to a quarter, and stem cell transplantation down to 73%. So a tremendous immediate impact from the pandemic. A lot of our work in PAHO has been with normative data, collecting information, really giving best practice evidence-based guidance to countries, providing support, technical support. And this is really continued work that we have done, and of course, working with partners. So that work continued, but also trying to make the case that there must be investment at all levels of the health system, particularly primary health care, so that we are able to mitigate future public health emergencies and crises such as what we've seen already.
Thank you. Thank you. No, those are excellent examples, and those three different initiatives really do address a wide variety of the issues of the cases of cancer that we do see in the region. And I'm happy to see that two of them are women's cancers, because I do sometimes think that women can be just lumped into marginalized communities. I know, Maria, Doctora Rico, that the America's Health Foundation has just finalized a regional analysis of both the economic impact of COVID on cancer diagnosis and care, as well as a wide-ranging survey of physicians, asking them what they're observing in their markets. What are some clear takeaways from you? And actually, what were some sort of surprises for you when you were going over the data?
Yeah, thank you, Alessandra, and thank you to the Inter-American Dialogue again for the space to have this conversation. So at America's Health Foundation, we decided to carry out a study to evaluate the impact of the pandemic on cancer care. We know that Latin America was one of the most affected regions in the world, and some of the typical public health priorities were displaced by the immediate demands of the pandemic, which obviously required both human and financial resources to be deviated. And within these priorities that were left unattended was cancer. So this study kind of confirmed our suspicions that there would be a pent-up demand and of the repercussions of the interruption in the continuity of cancer prevention and care. But something that I wanted to point out and kind of echo from the past panelists was that Latin America, even before the pandemic, was dealing with an increasing cancer burden. And many of the health systems were struggling with a lot of the issues that Christian was mentioning, inequities in care, fragmentation, funding issues, infrastructure that was not optimal, in many cases, a shortage of oncologists, and a concentration of resources in the main cities, which often leaves more rural areas unattended. So there was already this vulnerable state in terms of cancer care, and the pandemic aggravated these problems and widened the existing gaps that the region has been dealing with for so long, and kind of put them in the spotlight. So these are definitely not new problems, but it is an opportunity to finally address these issues. But now getting into a little bit of the results, the results of our report were unambiguous in the effect that the pandemic had on the entire spectrum of cancer care, which of course goes from prevention to diagnosis, treatment, palliation, and eventually survivorship. And the impact has been felt primarily in three aspects, which are cancer mortality, continuity of cancer services, and the economic impact, both for the patient and their families, and also for the health systems. And importantly, we did see a disproportionate impact on women, which of course is not surprising, but I think the thing that kind of impacted us the most is that the magnitude of the impact and how it appeared across the board, across nearly every country that was surveyed was shocking. So getting into a little bit of the hard data, so 93% of the oncologists that we surveyed reported an increase in patients with advanced stages of cancer due to pandemic-related delays. And for a disease like cancer, where early diagnosis and treatment do offer, in many cases, the best chance of survival, what this means, unfortunately, is that we're going to have limited treatment options for many patients, and we're going to be seeing unnecessary deaths. And consequently, in the survey, 87% of the physicians reported that they saw an increase in mortality of their patients. And now this increase in advanced stages of disease and mortality is very closely linked to the interruption of prevention and screening programs, which have been mentioned, of course, and this is one of the areas that is most worrisome, in my opinion, because we know that the best way to stop cancer are prevention and early detection. And in this case, 80% of physicians reported reductions in screening and prevention programs. And specifically here, 96% saw a decrease in mammograms, which of course are key to early detection of breast cancer. So again, what this translates into is that we're seeing women that are being diagnosed later with more advanced breast cancers and with less possibility of being cured. So in terms of disruption of cancer care, and echoing what Dr. Hennis has found as well, in our survey, all oncologists, 100% of those surveyed reported a disruption of to some extent of the cancer care continuum. And the primary reasons that were mentioned were overburdened health systems, lockdowns, and the fear of being infected. So this mentality that, we need to avoid infection at all costs. And again, we saw many patients' treatments were delayed or interrupted. Others abandoned their treatment entirely, again, either because they had travel restrictions, because their usual center closed, or because they were very afraid of being infected. The areas where we saw the main interruptions were screening, diagnostic services, and surgery across the board. Those were kind of standard across the board. Others like chemotherapy and radiotherapy varied between each country. But really, the impact of these interruptions is particularly critical in Latin American countries, because as Dr. Hennis mentioned, a great proportion of the global cancer deaths do occur in our region. So I don't know, Alessandra, if you want me to go into, I really would want to highlight the impact on women, which I feel has been a topic that, as you mentioned, sometimes gets kind of bunched in with the rest. But we found, there has been a lot of research showing that the pandemic has had a disproportionate effect on women in all areas, emotional, mental, physical, economic, work-related. And in this case, some of the key findings of the report evidence the same phenomenon in the impact on women's health in relation to cancer. So we already spoke of the reduction of mammograms for breast cancer. This is likely also true for cervical cancer screening, which is one of the cancers that is completely curable when caught early. So in terms of the economic impact, breast and cervical cancer actually combined were responsible for over 50% of the economic loss that we saw. So it really highlights the urgency of prioritizing these diseases specifically. And the impact wasn't only for women with cancer. So the pandemic also had a great impact on caregivers who are, especially in our region, predominantly women. They had to deal with innumerable challenges to ensure the care of their loved ones, and these included, again, the fear of infection, adapting to virtual modalities, overcoming travel restrictions and center closures, additional expenses to adapt their house, and losing their jobs. In many cases, we saw that a lot of the caregivers actually lost their source of incomes.
Yeah, I think that is not surprising, and with the America's Health Foundation, Catalyst collaborated with a patient survey with over 100 patient groups throughout the region, and the biggest takeaway there was this impact on caregivers losing their job, or caregivers having to stay at home, so therefore they couldn't care for the people that they would normally care for. As I mentioned, we have been working with patients and patient advocacy groups and civil society groups for a long time in Latin America. And one of the challenges we have is that there are so many priorities for health systems in Latin America. And as each one has mentioned, these systems are overburdened. Even in the primary health scenario, we find that there are limitations. So making the argument for more investment, and I'm not only talking about financial investment, but I'm also talking about human investment in cancer, is sometimes a hard argument for advocates to make. So I was wondering, from each one of your perspectives, with the stakeholders that you work with, what are some of the areas that you see where advocates could get most active to have the highest impact for cancer patients and cancer care in the region, where they should be focusing their efforts for making some significant change now that the COVID pandemic has changed the landscape for cancer in Latin America? I'll start with you, Dr. Christian, because you're nodding your head, and that's always a bad idea when you're on a panel.
Yes, I put myself on the spot. Sorry. No, yeah. So no, I was thinking that at the very least, there are two levels for patient advocates and organizations, and for them to act. But the very first thing is that we have seen an increasing number of patients, organizations, and civil society organizations working on this. That's the first good news, I would say. This is something that is positive for patients themselves and families, of course, but also for the systems. In many ways, for the legitimacy for those for health systems, right? To generate hopefully more trust in them, which is a problem in general. The trust in institutions in our region, that we as citizens, people is trusting less in institutions in general, including in many ways health systems. So I think the civil society and patients generate this bridge in between. So then more practically, I think, of course, you can immediately think in the community. So civil society organizations can bring people and patients and families to connect and to generate the new information and to put them in touch with all the resources that are available in the system. So that kind of things, and also to how to help them how to navigate through the system. So I think those are very good things that patients from the experience can do. And actually there is this concept of experts from experience, right? That can help in general their peers, but also at other levels. And then the second tier that I was thinking is at the macro level. Of course, in between there are more things, but at the macro level, we know that there are experiences. And again, from Chile, I was involved in the process of approving and then implementing the high-cost treatments law for coverage there. That is called the Ley Ricarte Soto. That's the kind of the colloquial name of the law. And of course, many of these treatments were for cancer, right? The cancer medicines, high-cost cancer drugs. And this is a very good experience, I must say, in terms of how institutionalized participation of organized patient groups. And they even, these patient groups have democratic processes to define who will represent them in the processes of the law, and they can actually vote. They not only give they have voice, but they have voting power in then making the recommendations for the ministers of health and finance to make the final call in terms of what to include and to cover through this high-cost treatments fund, right? So at the macro level, I think this has been also a great improvement. I know Mariana is in Colombia. I know you have also in Colombia a cancer law, and I imagine that has helped also to mobilize civil society. So these are very good examples at the, as I say, community level, and then at the macro policy level, which is so important, right? To generate things for the whole population, hopefully in a more universal and equitable way.
Thank you. Thank you. That's great. One question came in from the audience about what the name of the high cost to medicine law is in Chile, and it's a Ley Ricarte Soto.
Ley Ricarte Soto.
It's named after a policymaker who had cancer himself and had needed access to high cost medication. Dr. Hennis, I want to ask you, going back to this idea of prioritization and how people make decisions in terms of cancer, how did PAHO come up with these three initiatives: childhood cancers, cervical cancer, and breast cancer, and what kind of process went into that?
Yeah, okay, you've asked a basic but a fairly complex question. Because again, it tends to favor women and children. And I think these are groups that have traditionally been neglected in many of the clinical and health-related spaces. So I think their needs, children, for example, quite often childhood cancers are not preventable. There are no clear risk factors. But yet, if you can develop your human potential and reduce suffering and mortality, you're looking at a generation who can contribute to be meaningful in terms of national development. So I think that sort of underpinned trying to save children and trying to have strategies and policies for cancer for children. Women, of course, 50% of the global population, just over 50% of the global population. And I think the important thing to stress here is that the cancers were breast cancer and cervical cancer. Cervical cancer is actually possibly and probably the first chronic non-communicable disease that can be absolutely eliminated. One can potentially eliminate cervical cancer. I spoke a little bit earlier about the disparities and the fact that it is more prevalent with worse outcomes in lower income settings and countries. And it is eminently preventable by human papillomavirus vaccination and early screening and early detection and treatment. So everything is there. It really requires that there's increased uptake of services that are quality services that can provide and meet the needs, right? So I think we have a mix here that can lead to successful outcomes. And of course, breast cancer is the leading cause of mortality among women. So there are different reasons, but it all comes to the same endpoint: improving well-being among populations, saving lives. Now, I think I'm going to take a little bit of the question that you raised also to Christian about the need for investment, resources at the very different levels. And I make the point that PAHO recommends that 6% of public funding is invested in health. that's a level of investment that few countries actually reach. And the need for this level of funding is to build the necessary health infrastructure through investment, build the necessary human resource for health, build the services, etc. But the investment has to be part of it. And in addition to that also, I will use the opportunity to share with you the fact that as you talk about cancer medications, the PAHO Strategic Fund actually is a mechanism through making medications, particularly high-cost medications, available to countries. And it does it through technical cooperation. It does it through pooled procurement. So when there are many countries on board, one is able to negotiate the best prices. It also builds technical capacity in countries. There are mechanisms to ensure quality assurance, so the drugs do what they are supposed to do. They're quality drugs. And also is a mechanism which has innovative financing as another pillar of the PAHO Strategic Fund. So these are mechanisms that reduce cost to countries and provide much needed medications for cancers. So I think here's an opportunity to share this in terms of this public platform. But I think these are mechanisms that actually make access to medications for cancers far more within reach of many individuals within countries.
Thank you. And obviously, with the advanced stages of cancer that are going to be presenting into the systems, this procurement, regional procurement will help governments be able to have access to more medication. Yeah.
Exactly.
Right. Dr. Rico, I feel like the research you've done at the America's Health Foundation really generated a lot of evidence base for what's happening in the region and the impact of COVID on cancer. What are 2 or 3 key policy recommendations that you can see coming out of the research that the research could support from an evidence standpoint?
So as Cristiana was mentioning, policymakers in countries like Colombia, Chile, Peru, even before the pandemic had made some advances in national cancer laws. But the main thing here is that these laws need to be supported by sufficient funding and investment in technology and infrastructure. And I think one of the most important things to recognize is the repressed cancer burden generated by the pandemic. And this seems a little obvious, but I think it's worth highlighting because if we don't recognize this pent-up demand and continue as if it had not happened, we will very likely continue to see the negative repercussions on patient outcomes and the sustainability of health systems. I think definitely investment is one of the main issues here, but something that I did want to touch on now that you brought up advocacy, participation, is the importance of collaborations between the public and private sectors to generate any transformation in the health sector. I think any of the efforts we can recommend to address the challenges that we've mentioned require coordinated efforts between all the different stakeholders. And these include civil society, government, academia, medical societies, industry, to find solutions and build policies that will strengthen the health sector and ultimately improve patient outcomes, which is what we want to achieve. And there have been some pretty good examples of this already going on, even during the pandemic. But this definitely is something that needs to be strengthened. And the other thing we've seen now, the fallout that the interruption of the continuity of care results in. So we have a very clear view of the importance of ensuring this continuity of cancer care, even throughout crises, whether it be another pandemic, natural disasters, conflict, whatever it may be. There are definitely lessons that we can learn from the pandemic to build crisis preparedness and have better responses for the future.
Great, thank you so much. And I think your comment about investment is very important, but also the idea of repressed care, because I think we're all suffering from pandemic exhaustion, and our preference is to pretend it's over and we can just go back to our usual work. But our usual work is going to be changed, and for those of us who work in cancer, and it's permanently changed. And we need to address the cancer burden that we have now, not the cancer burden of 2020. And that will mean that there needs to be more investment in more advanced therapies and other ways of supporting patients, given the fact that they're going to be presenting in later stages. There's really great points that are coming out of the research that you've done, and also the expertise on the panel. We are at the point of the session for questions and answers. We have a couple coming in now, but I wanted to, the first question is coming in from Regina Garcia from the Associated Press de Caracas. And I think it's geared towards you, Dr. Hennis, where she asked, the WHO's goal to have HPV vaccines delivered to 90% of adolescent girls by 2030. She wants to know, should that goal, particularly as it relates to Latin America, be revised given the impact of the pandemic on health systems?
Well, okay. Thanks for the question. And I'll speak about the global strategy to eliminate cervical cancer as a public health problem. And it defines elimination as an incident threshold of 4 incident cases per 100,000 women. And so the target is to have 90% HPV vaccine coverage, 70% screening coverage, as well as 90% treatment coverage. Now, the issue is that since we've had setbacks because of the pandemic, should we revise the goal? And the reality is no, we should scale up the goal. We should try to work even harder as we transform, recognizing that there was delayed care, there was probably even there's postponed and delayed care. And there's some women who might have progressed to significant levels because they were not able to access care. So I think we have to deal with the fact that there's actually going to be an accumulation of persons who are in need of treatment, which was delayed, treatment and detection. So ultimately, we actually have to work even harder to roll back out the program so that we do not then further delay care and increase the number of women who are at risk of having worse outcomes because of the pandemic-related delays. So I think one has to take the opposite perspective, work even harder so as not to exacerbate the losses that we've seen so far because of the pandemic.
Right, I agree. It shouldn't be an either or. And I think sometimes that's what happens with cancer, is it's the harder thing to address. So we start addressing everything else first. Dr. Herrera, do you want to build on any of these comments around policies and cancer care?
Yes, thank you. No, I think just to complement and maybe move a bit, complement to what Mariana was saying, because absolutely, and we have lessons learned from the pandemic. That's the first thing, right? Now we are starting to know what worked better, what were the changes that in some way the pandemic pushed forward. The thing that everyone is talking about is about digitalization, so telemedicine, and how we can use that in normal times, right? And has improved and moved this forward decades, many are saying, right? So that's one of the most obvious ones, but there are others. And one is what Mariana was saying about public-private collaboration. One of the fragmentations that I was mentioning before was between public and private, right? We have portions of the populations mostly receiving care in the public sector, and other portions of the population, usually the wealthiest, receiving more and in the private sector, right? So this is obviously like a general statement, but that's the trend across the region, right? And what happened during the pandemic is that the crisis in some way forced systems to work as one single system. And in most of countries, I must say, the ministries of health and the health authorities in the end took the stewardship and well, in Spanish we use the word of rectoría, like taking charge of the whole health system and coordinating and giving all the the signals and regulations to have these two sectors providing in general terms, the same care for any person, right? This respecting of the type of insurance and so on. So this type of one single system, I think it gives a very good lesson learned. So to cope with the crisis, countries had to work as a one system with the public and private sector, and this could be the way forward in the future. That's one thing. So. And how to organize this, we are thinking of health systems reforms and policies, such as the ones we are talking about, and also the revolving fund. I think it's a great example of something that relates to the health systems, and an example that even OECD countries, high-income countries, look to learn from the revolving fund, and how to improve the spending of existing funding, right? So we can make even better use not only of new funds, but existing funds, if we include more there. And it's a great example of regional health diplomacy at the same time. So then another part is risk factors policies. So it would be great if we can move forward in terms, for example, of taxes for risk factors for health. And we know that tobacco, alcohol, food, highly processed foods, and so on. Then labeling policies, we have good examples of that across the region, different countries, Mexico, Uruguay, Chile, and others, Ecuador, using that type of policies that helped people to make better decisions when consuming in terms of food consumption, and so on. So risk factors, that's another one. And the third is health system resiliency. As I was saying, this is obviously linked to health systems, absolutely, but requires a different strategy. It requires different sets of policies to plan, and then to be able to respond in crisis times. And let's be sure that more crises will come. More crises are happening in the region, and this is a priority. And from the World Bank, and I'm sure all the actors here agree that this is something that should be kept high in the agenda, because the pandemic most likely will go, and we hope sooner than later. But this can take this type of areas out of the agenda, and we shouldn't do that. So let's try to keep it there.
Great, thank you. I think the idea of the taxes and the lifestyle changes is a long-term issue that not only Latin America is addressing, but the whole world is addressing, and having some sort of coordinated and multi-sectoral whole society approach to that, including urban planning and including food deserts. It's going to be a complicated response, but something that is urgent. We have a couple of questions here. The first comes from Patricia Gallardo. She was the director of the National Cancer Institute in Argentina until December of 2021. And she says that we must work hard on the subject of regional public policies with real impact. Was the percent drop in cervical, breast, and colorectal cancer screening known in each country? In Argentina, it had dropped almost 50% from the pre-pandemic levels. Do we have that kind of data? That's probably more of a PAHO question, I think.
Yeah, there are data coming in. It's not necessarily available for all countries. Some countries in Latin America have pretty robust information. Some of the smaller countries in the Caribbean don't. So the question is a mixed picture. And as time goes by, as the data is sought, we're getting clarity in terms of what's actually happening in terms of individual countries. But it's an ongoing situation in terms of the impact of the pandemic in terms of screening. And it really depends. Those which had better data systems can answer and respond a lot earlier than those where the systems are far weaker. Right.
And here's a question, and I think this touches on the issue of the primary care systems in our countries. This comes from Frances Villafane from the American Cancer Society, and she says that ACS just launched the Get Screened campaign with the goal of increasing screening for breast, colorectal, and cervical cancer, as well as HPV vaccine uptake. The priority of this campaign is to target local primary care systems and regional hospitals. Do you think that mirroring this type of strategy in Latin America would work as well?
Yeah, well, I will actually answer by saying we actually have these programs ongoing, certainly for breast and cervical cancer screening in Latin America and the Caribbean. Those are already in place, and we're quite happy to share some information on that. But this is where the PAHO has actively been doing. And I will also note, just to follow up on what my colleague Christian said, and I appreciate him being a very strong advocate for work as well. And I'll just make a little thing on the side that Christian and I actually collaborate quite deeply, so we know each other. And really, prevention of cancers through risk factor prevention is critical. And I think what we saw during the pandemic was that a lot of these gains were actually being reversed actively in some cases by the relevant industries. And I think it's really important, for example, tobacco, one of the principal drivers of cancer. We have to make sure we preserve the gains in this region. And just to let you know as well, that South America was the first multi-nation continent in the world to become free of tobacco smoke in public spaces. So there have been tremendous gains in the region, and I think we have to continue to advance and scale up what we've already achieved. Christian mentioned things like nutritional front of package labeling and so forth. This region has been a pioneer in terms of rolling these out, and our organization working very closely with member states to support them in terms of allowing consumers to have the necessary information to make the right decisions in terms of what they purchase, particularly related to processed, ultra-processed foods. And we're going really for healthier foods, low processed, for no processing, natural foods. And I think this is all part of what a healthy lifestyle looks like. Colleagues spoke about physical activity, and you spoke itself about urban planning. We also have to reduce air pollution. So there are many, many elements that all have to be changed to achieve the endpoints that we're looking for in terms of prevention. And this is in addition to.
Yeah, and I think your point about how there has been a backslide during the pandemic is especially true. I mean, I think that we all talk about the pandemic 15, that people have been drinking more, you know, like that isolation and that lack of communal support has meant that that people have slipped into the lifestyle choices or the lifestyle necessities just to get through a pandemic that might ultimately increase their risk for long-term negative health impacts. And so redoubling our efforts going forward is very important. I want to now hand the microphone back to Rebecca from the Inter-American Dialogue. I myself have found this panel very interesting, and the research and the work that all three organizations are doing are going to push the evidence base forward and help people who are suffering from cancer, but also populations be able to prevent their own cancers going forward. So Rebecca, thank you so much for pulling this all together, and thank you to your great team, Devin and Eric. And thank you to our great panelists, Dr. Herrera, Dr. Hennis, and Dr. Rico.
Thank you. That was such a wonderful conversation. I learned a great deal. I think it's nothing short than a call to action. I really appreciated the focus both on short-term and long-term solutions or recommendations, and also the need for a real whole of society approach. So thank you so much for that. I want to thank all of our panelists, Mariana, Anselm, and Christian, and Alessandra, thank you so much for moderating with such skill. Before we close out, I just want to remind everyone that the Inter-American Dialogue's annual gala, it's the Leadership for America's Gala. It's going to take place on November 2nd. It's going to be in person and indoors this year at the Mandarin Oriental Hotel in DC. Please save the date and visit our website if you are interested. And also just please reach out in general if you're looking for other ways to engage with the dialogue. With that, thanks again to the wonderful panelists, and thank you all for joining us.